anesthesia for fetal surgery. Okay. So, fetal interventions is basically a rapidly evolving field. Now, with the advancements in imaging and genetic studies, they've led to like a wide range of fetal interventions which can be done through different stages of pregnancy. Now, during these surgeries, it is important to understand that the mother is an innocent bystander and she doesn't stand to like directly benefit from the surgical intervention. That is why the potential benefits to the fetus must be carefully weighed against the risk of the mother that is there for the mother. Okay. So the goals of anesthesia for fetal interventions include ensuring maternal safety, maintaining the uteroplacental perfusion, and minimizing the fetal risk. Okay. So now there are three main types of fetal interventions. That is, you have your minimally invasive techniques, you have your open mid-gestation surgeries, and you have the exit procedures. So now let's discuss the first type, that is the minimally invasive type. So these are the most commonly performed as of now fetal interventions. They include both your ultrasound guided needle based techniques as well as techniques using a fetoscope. Basically, they access the uterine cavity percutaneously with needles and small sheets. Now, the structures are visualized by either your ultrasound or the fetoscope that is inserted through the sheets. Okay. These procedures are usually performed in like early gestation or mid gestation. And either you can do it under local anesthesia or neuraxial anesthesia with or without maternal sedation. The next type, that is your open surgeries, mid-gestation fetal surgeries. Now, these surgeries are performed via a laparotomy, okay, and they're usually performed under maternal general anesthesia, okay. You basically do a laparotomy, and the access to the uterus for repairing the fetal defects is done by a hysterotomy or under a fetoscope guidance. You need profound relaxation for these cases. So uterine relaxation is achieved with either your volatile anesthetics or your intravenous agents. After the intervention is performed, the uterus is subsequently closed and the pregnancy is continued to deliver at or near term. Now, it is important in these cases to maintain tocolysis postoperatively to prevent preterm labor from occurring. The most commonly performed fetal interventions are in this mid-gestation procedure is the meningomyelocele repair. Now, coming to the third type, that is the exit procedures. Now, these procedures are usually performed at or near term, and it's like basically a bridge to delivery to allow like life-saving fetal interventions to be performed before delivery and before separation from the placental circulation. The most common indications in this is when you have to secure the fetal airway, like in cases when there's like severe airway obstruction from your oropharyngeal masses, or there's severe micrograthia in a syndromic child, or some mediastinal masses, and even debulking of sacrococcygeal teratomas can be done by exit procedures. The cardiac procedure, which can be done is in cases of fetal bradycardia, is the epicardial pacemaker insertion as well. Now, most of these procedures are performed under maternal general anesthesia, but neuraxial techniques have also been described for these procedures. Similar to like your mid-gestation surgeries, uterine relaxation has to be done before the hysterotomy, okay? And the difference is that post-operative tocolysis is not required in these cases. After completing the intervention, you discontinue your volatile agents so that the uterine tone can come back, okay? And after you clamp the umbilical cord and deliver the fetus, you have to give uterotonic drugs to improve the tone of the uterus. Now, the newborn is then transferred to the adjoining operating room for resuscitation and further stabilization or surgery if required in the immediate room. Now, exit procedures are different from the other two interventions because in these cases, the fetus is delivered at the end of the procedure. So let's understand a little bit about the fetal physiology. Okay, like you need to know everything about the maternal physiology also, but a detailed review of the physiological changes of pregnancy is beyond the scope of today's lecture. Okay, so let's just see the fetal physiology. Now, whatever we discuss in fetal physiology, it's actually these are more determined from animal data due to logistic and ethical issues in human studies. Now, a fetus has increased sensitivity to volatile anesthetic agents like the studies have shown that, especially with halothane and isoflurane, that's the one that's been studied, the anesthesia requirement in fetal lands is lower than that of its mother. So this can be extrapolated to our human fetus also. Now, noxious stimuli elicit a physiological response in human fetus, and this has been evidenced by an increase in cortisol and beta endorphins. Now, these responses are usually attenuated by administration of fentanyl directly to the fetus. Even though the pharmacokinetics and pharmacodynamics of fentanyl have not completely been studied, but this response has shown to be attenuated. Now, in the second trimester, a fetus can mount a stress response to a stimulus, which is blocked by the administration of analgesics. But how this stress response correlates with pain is unclear, because this stress response is also seen in adults under deep anesthesia. So basically, fetal pain perception is a hotly debated topic. Okay, earlier it was believed that the fetus does not get pain at all, and analgesics were avoided at that time. But now newer studies have contraindicated this. So about by 25 to 30 weeks of gestation, like the thalamocortical connections to the somatosensory cortex develop that allow perception of pain. Now, noxious stimuli have been found to elicit a hemodynamic as well as a neuroendocrine response as early as 20 weeks of gestation. Therefore, it is recommended to provide adequate fetal analgesia for invasive fetal procedures. Now, not all interventions will require analgesia, because it's the umbilical cord and the placenta do not have any pain receptors. So, the interventions which are involving these tissues do not require fetal analgesia to be given. Okay. Now, the cardiopulmonary physiology of the fetus. Okay, so it is important to understand it's not dependent on the lungs, because your placenta acts as the organ of respiration. Now, the major role of lungs in utero is the production of amniotic fluid. The lung epithelium actively secretes this fluid, which fills the lung, and the excess of it will then pass out to the trachea and the oropharynx. It is either swallowed or it's expelled into the amniotic space and becomes a part of the amniotic fluid. When this fluid, the egress of this fluid is restricted, it can lead to pulmonary hyperplasia, whereas over drainage or continuous drainage can result in decreased development of the lung or pulmonary hypoplasia. Okay. Now, fetal circulation is notable for being a parallel system prior to transitioning to the serial circulation at birth. The ductus venosus, okay, it will allow most of the blood to go from the umbilical vessels, bypass the liver, and go directly to the inferior vena cava. Now, the foramen ovale and the ductus arteriosus allow mixing of blood between both the right and the left side of the heart. Oxygenated blood will travel from the umbilical vein into the right atrium, and preferentially from the right atrium, it will go across the foramen ovale to the left atrium. From there, it goes to the left ventricle to supply the most oxygen-rich blood to the brain and to the preductal circulation. Deoxygenated blood will return from the superior vena cava, and it preferentially travels to the right ventricle via the right atrium. Most of the blood from the right ventricle then goes from the pulmonary artery via the ductus arteriosus to supply the postductal circulation. Enough mixing occurs in this so as to supply necessary oxygen to the lower extremities or your postductal circulation. Blood goes from the aorta to the iliac arteries and back to the umbilical arteries and placenta, where gas exchange occurs. So, fetal cardiac output, because it's a parallel circulation, it's usually measured as a sum of both the left and the right ventricular output, and it's called as the combined cardiac output. Now, echocardiographic studies have found that a normal human fetus has a combined cardiac output of around 425 to 550 ml per kg per minute, with most of this, that is about 60 to 70%, being contributed by the right side of the heart. Now, as we've seen in neonates also and infants, the fetal myocardium has more of the non-contractile elements. And basically, it's stiffer than the adult myocardium, and there is impaired relaxation. Okay. So it lies on the upper limit of your Frank-Starling curve. So that's why increase in preload will not provide so much increase in stroke volume or cardiac output. So to actually cause a change in cardiac output, it is the variations in the heart rate which provide the changes in the cardiac output.